Good morning, everyone. Thank you for joining us on this Friday the 13th. We have an interesting case today with Dr. Kim, who's going to be showing us a case of a splenic artery aneurysm embolization. Also joining us today is Dr. Emil Cohen from Georgetown University down in DC, who's one of our former fellows, and he's going to help us moderate this case today. So, Dr. Kim, do you want to start introducing everybody and get the case rolling?
Emil, we were co-fellows here at Mount Sinai together, so it's nice to see you again, Emil. We have our whole team here. So our technologist is Giselle. Our nurse assisting us is Krizia. And we have our anesthesiology team here as well. Liz is with us. And our PGY6, Sid, will be presenting the case.
Everybody, good morning. My name's Sid Kulkarni. So today we have an interesting case of a splenic artery aneurysm. So short, brief presentation. This is a 62-year-old female. She has a past medical history of diabetes, asthma, COPD, seizure disorder, as well as HCV cirrhosis. And she's had a history of encephalopathy and ascites, but no varices. She had a recent screening CT that demonstrated an approximately 1.9 centimeter splenic artery aneurysm in the hilum of the spleen. She additionally also has a 22-pack year smoking history. She's quit smoking about 2 years ago now. Based on the screening CT where they saw the splenic artery aneurysm, she was referred to interventional radiology where we saw her in our office hours. When we saw her, this was our physical exam and initial lab work. Her physical exam was largely benign. She had some edema in her ankles, but her abdomen was soft, non-distended, no bruits were auscultated, and all of her lab values were mostly within normal limits. This is the CTA that was performed. So first is an axial slice. And you can see right in the hilum that there's a splenic artery aneurysm. You can see that again in coronal. You can see that it's right at the branch points as it goes into the spleen. And then here's some still axial and coronal images, and you can measure it up to 1.9 centimeters in the axial plane. It's a little bit oblong. So in assessment, this is a 62-year-old female with a history of HCV cirrhosis. She has evidence of portal hypertension. She's found to have an approximately 1.9 to 2 centimeter splenic artery aneurysm on screening CT. Given the size, usually we treat these around 2 centimeters. So she's right about that margin, but also with a history of portal hypertension, we thought it was prudent that we treat it today. So today we're performing a splenic artery aneurysm embolization via femoral approach. And our plan would be to see her in 1 month in our office again with an MRA to see how the aneurysm sac is.
Great. Thanks, Sid. Any questions up until this point?
Yeah, so classic teaching for splenic artery aneurysms, right, is around 2 to 2.5 centimeters in terms of treatment.
Mm-hmm.
But in these patients who are portal hypertensive or obviously pregnancy or childbearing age, we sort of lower that limit. So how do you counsel these patients? And in terms of also this one's a little bit more distal, I think, than some of the other ones. So how did you counsel this patient?
Yeah, so our hepatologist sent this patient to us, and as with all of our patients, we speak with them in our office hours and consult them in terms of the risks, benefits, etc. And she did not want to kind of sit on this and have it screened on an every several month basis. And so she wanted to pursue embolization of this. And so she did not like the risk of just waiting, potential risks associated with a splenic artery aneurysm. We did also counsel and discuss on the location of it, as you had mentioned. It is more distal near the hilum, which could lead to splenic infarct. But to be quite honest, when we spoke with her, we spoke with our referring hepatologist. She has splenomegaly, portal hypertension. It might not be such a bad thing to have a portion of this actually have its blood supply reduced. And so she wanted to go ahead and embolize this. Her proximal splenic artery is about 7.5 millimeters in size. And so, this is well over 2.5 times size of the vessel, just proximal to it.
And the other thing is, as you mentioned, it comes to us from our hepatologist. We obviously have a good relationship with them. So we tend to get a lot of splenic artery aneurysms through our actually liver cancer and liver screening program as well. Emil, how are you guys managing or seeing your patients for splenic artery or mesenteric aneurysms?
Hey, real good to see you guys. Thanks for having me. Yeah, like you said, we get a lot of referrals from our hepatologists because, these guys have a high prevalence and the patients have portal hypertension. I think their guidelines say it's up to 15% of these guys with cirrhosis and portal hypertension have these things in them. and they recommend like the 2-centimeter cutoff. And he said, especially for people, and our guys here really like us to try to treat them if they're going to go under transplant, because they don't want any surprises in the OR, let's just say. They like us to get at them, just like you guys are doing.
Just to go through some images, we went from a femoral access, and then what we did is we have, in terms of our equipment, we have a 6 French guide, the catapult, with an MPA angle to it. And that's when we looked at the cross-sectional imaging ahead of time, we felt the MPA with a slight angle would be favorable for us to seat that MPA guide into the proximal splenic artery. That way, we chose a 6 French system instead of a 5 French system, because we can do angiographies through the guide. So once a microcatheter is in position, we've coiled to see what the flow is like around that. We won't lose access. We'll just do our angiography through the guide, and it will go around the microcatheter. For this case, we chose an 0.16 fathom wire, 180 cm, with 130 cm 2.4 French direction. The reason we chose the direction is you can get extremely high flow rates through it. And as you know, in the splenic artery, especially with splenic artery aneurysms, they can be an extremely high flow. So we didn't want that to be any limiting once we're using our microcatheter to get in. Obviously, we can also do runs through the guide, but we wanted to have access through the microcatheter as well. And so it's a 1200 PSI. We can do up to even 4 cc's per second through it, but we did a 3.5 cc per second injection once we were in the aneurysm. And then we plan on probably using coils. You caught us right when we gained access with our microcatheter to the aneurysm sac, and we can talk about whether we should go even more distal, potentially try and hit the outflow, or just hit the aneurysm sac itself. So here are images through our guide doing angiography. It goes around the microcatheter, and you can see the flow into the giant spleen here. And then this is a run through the microcatheter itself. Again, this is quite close to the hilum, so you do worry about some compromise to the distal portion of the spleen, but as you know, there is a bunch of collateral, so we can continue our discussion if you'd like.
Yeah, so given, how distal, we've all had this thought, like, oh, should we try to do like a stent assist coil or try to put a covered stent to preserve the distal flow? So what are your thoughts on that? And
correct me if I'm wrong, Rahul. I mean, you might be first author. I don't remember, but our group published our experience on splenic artery aneurysm embolizations, and we might have one of the largest series that's been published. I don't think any of them were stent-assisted coiling.
I mean, I don't know if Dr. Cohen has any different feelings on it, but it always looks like you're like, oh, this would be a great case to do a stent or try to put out a covered stent. And when you get there, like, there's no way, like, given all that tortuosity, if you look at just the microcatheter whipping around back and forth there, like, there's no stents going to track out there that's going to be big enough to do that. And then especially like trying to get a Viabon or a VBX out there, it was like very proximal. That's probably where you could probably do a stent, and then it's sort of pointless at that point, right? Because it's so proximal that it's just easier to coil. Like, what are you trying to preserve at that point?
Yeah, just like you're saying, Earl, it's like when you get these cirrhotic patients, their aneurysms almost always at the hilum. I wish we got some aneurysms like proximally to a stent graft. I think in our whole life we had one case where we could put a stent graft across the proximal aneurysm. And most of the time, like you said, especially in these patients, are in the middle of the hilum. So.
Yeah.
Question: do you guys? And I'm just mentioning this because some people do, and I don't agree with this. But do you guys like vaccinate these guys in case the whole spleen gets infarcted or anything like that beforehand, or give antibiotics or anything else?
Yeah, I think that's kind of the older type of thinking with this. People would worry about potentially encapsulated vaccination, but I think that's really fallen out of favor in the sense that there's no evidence to support that. And so, no, we don't do that.
Yeah, we don't take out the whole spleen, so it's kind of unusual to need it. Yeah, go ahead. I'm sorry, Ro.
Yeah, exactly. That's what I'm going to say. We don't really take out the whole spleen. Even when we do partial splenic embolizations for low platelets or things like that, we're not really giving them. Obviously, we're giving them antibiotics because that's sort of part and parcel, I think. And Ed can correct me if he feels differently. But if we do at the end of the procedure see that there's an infarct, depending on the size, we may send them home on antibiotics. But we don't necessarily do it.
Yeah, I agree with that. Yeah, agree with that. Yeah. While we're chatting, I just for fun, we decided to go into the outflow vessel. But again, I'll leave it up to discussion. Do I need to go into the outflow vessel here? Are we sufficient with just coiling the sac, or should we coil back? Historically, people will say, "Oh, well, you need to get the outflow vessel."
Yeah, my thing is, I don't think you need to, because also I think you're going to fool yourself if you think there's only one outflow vessel out of this thing, right? Like there's probably going to be at least two, if not three. Yeah. So unless you're going to go into every single outflow, and I've not seen a retrograde endoleak, from a coiled aneurysm, meaning even if it's incompletely coiled, that the vessel fills backwards into it, right? Because all the flow is going to go through this place.
And then you also increase your infarction risk too, which is something you want to avoid.
Yeah. Yeah, I think if there's a more proximal aneurysm in the main splenic artery, I think I would maybe do the outflow, the aneurysm, and then the inflow, like just sort of coil across. But distal here, I think you're just going to pack it and then maybe coil the inflow a little bit, or plug the inflow if you want.
Okay, so I am back in the aneurysm sac, and as you stated, there's probably more than one outflow here. So might be more prudent, as both of you have suggested, just to coil the aneurysm sac itself. We're probably going to start to do that. Let's get a coil somewhere around the size of 20 millimeters, longest that you have. So what are your thoughts in terms of embolization techniques? Emil, how would you approach this?
Well, fortunately or unfortunately, depending on your viewpoint, we have a ton of different coils now, right? It comes out to what you're happy with or comfortable with your tortuosity. This looks really tortuous, so you need a softer coil. I don't fault anybody for using whatever coil they're happy with, and what you have available. But I like the fact that you picked the longest thing possible, just to, reduce the time, as we say.
Sure. Now, thoughts, both of you, on with that kind of size? Are we talking here fibered? Are we talking non-fibered? Is there a difference? How does it feel, either of them?
Depends on what you prescribe to, right? So I think in terms of data for aneurysms, that most of it's from neuro, and in terms of durability, they're unfibered coils and looking at packing density. So that 24 to 27% packing density, on the peripheral side, we don't really do that. And it's a little bit different because we can also coil the inflow, which obviously in neuro, you can't really do that kind of stuff. There is some data, not necessarily with aneurysms, but more so with vessel sacrifice in terms of fibered coils being a little bit faster. I think I'm not really sure. We have data to show that one is really better than the other,
Yeah, I completely agree with you too.
Thanks for that added commentary, Emil.
Just messing. We've called this before.
Completely. Yeah.
Yeah, I think, in terms of Emil's point earlier, in terms of the types of coils we have, there are luckily most of the sort of newer generation detachable coils, they're all basically soft. Most of them, I would say the vast majority of them will make these turns and these twists, whether they're going through a 2.8 French, 2.5 French, or 2.4 French microcatheter. You do have to take that into consideration, though, I think, with some of the coils, in terms of how you're going to build your platform to get yourself out there, and then that's going to sort of lead you to which coils you're going to have to use, Yeah,
well, since
For sure.
We're having fun together now, let's have a discussion. I think after the first detachable coils, why would you waste money on detachable coils on this afterwards? You can just probably puff it in a few, right after you get your framework in, right, Ed?
You could, here we are using a detachable coil. We're using an Embol. What was the size of this?
2050.
20 by 50. It seems like it's coiling quite nicely. A little piece of it went into an outflow branch, but that's okay. And this is fibered. We're not using the soft here. We could, but I like the fibered as well in the peripheral application. There was a study, I think, out of Hopkins that compared different fibered versus non-fibered, and they did show in, I believe, animal studies that it occluded the vessel much quicker with a fibered. Now, it gets a little bit messy here, I will admit, because I've implanted my microcatheter into the aneurysm sac. And so as we push more of the coil out, where it's sometimes quite difficult to see the tip of our microcatheter. And so maybe that also has to potentially why Emil might prefer something like a pushable coil, because that way it's completely out. With here, it's a detachable mechanism. You can still push it out if it's still left in your microcatheter, but the whole point is to obviously position as you see fit, and then ultimately detach it. This is a nitinol pushing system, so works quite well, as both of you had mentioned, around the tortuosity, and it won't kink, which is sometimes a source of consternation for some people. I assume that the camera is at my hands, and so nitinol, you can really bend it back and forth, and it won't kink. And sometimes the older platforms with the steel mandrel, you'll be pushing against some tortuosity, and you'll have a kink, and that really does kind of limit the ability to push through that. So this is, I think, quite nice. And then the detachment mechanism, sometimes there's a separate handle involved or some other mechanism to deploy it. For this, there's really two white strips, and in between there is no white. That's where you break like this. You just snap it, and then there's an inner wire that will pull and detach. So it is now detached, and we can pull our coil system back, and the coil is now detached. So we are going to get another 20 by 50-ish, and then we flush in between every coil detachment. So let's get back to some of the discussion while Sid preps for the next coil.
So like in terms of like microcatheter, as you said, like your catheter is buried in there. I kind of like the dual marker catheter systems, just because you can see, where you can see where you don't need to know where your tip is. At least you know where the detachment mechanism is going to come out, right?
I would like to emphasize the nitinol wire is very useful, because like usually it's just the fellow, but if they're really aggressive about pushing it in, you bend that proximal part and it gets really hard to push the rest of the coil in through the catheter. It's kink on it. So.
Or you get premature detachment, right? Especially with some of the coils. Yeah, so it is nice. And Emil mentioned, you could create a frame with just detachable coils and then put in non-detachable coils after, which works. The issue always becomes is the length, right? So how many you end up having to put. It's still more cost effective, right, than putting in these sort of long detachable coils.
So as we're talking, please feel free to comment, Rolai. What's happening, or Emil. You can see that it's flipping into the outflow, which is what we kind of don't want. So I've just been wiggling my microcatheter back and forth to try and have it go more into the mass, which is what it's doing now. And there it's flipping into the outflow, so I'm going to just mess around with my microcatheter. Yeah.
Do you ever put anything else in after, obviously you put a bunch of coils in, and put anything else like gel foam or glue or something in there at the end if you're having, like, to finish it up basically? At what point do you do it if you decide to go that way?
Rahul, you can take that question.
Yeah, I mean, I've done that in like trauma cases where I've coiled a plexus splenic artery and it's just not shutting down fast enough. Part of that is my own impatience, just not wanting to wait. I've used liquids for an aneurysm before, more so because I've just got tired of we just put so many coils, just sort of mix some onyx, or EBOH 34 and just slowly push it to sort of seal up the rest of it. Some of it could just be just patience. If you just wait long enough, they'll thrombose. Obviously here it's a little too early just because it'll just all leak out the outflow. I don't know, have you used liquids?
No, exactly, just like you said too. I at the end because as Ed knows, I'm a little bit impatient too, so I
Really?
didn't like roll any and you get near the end, you're like, as long as I feel like it's not going to go distal, then I'll start using like a little bit of gel foam or glue to shut it down. Just one question: these embols are made out of what, titanium? What are they made out of? The coils. I'm just trying to see how you're going to follow up with MR, or what do you plan to follow up?
Good question. Yeah, so the coils themselves, are they platinum? Yeah, they're platinum. So they do have artifact when it comes to following up with CT. So actually, Emil, the protocol that you came up with is still in vogue here. And so we follow up with an MRA for these patients to make sure that it's completely occluded.
Yeah,
This is
just
the
like you
third
said,
coil, by the way, that's going in.
yeah, this plasma makes it harder to see like on CT, but it's great for MR, so that's nice. That's really good that you can get this. Thanks. And that's a downside with the pushable coils because some of them are still stainless steel and cause a lot of artifact on MRI.
Yeah, no doubt. You can see it's packing in quite nice.
Yeah.
Because I am also a little impatient, we can actually do a puff. We're not going to see anything, but just to take a peek. We're all, I think, by nature, a little impatient. So I'll just show you why we use the guide cap, because now we can puff and see exactly how much we've potentially occluded. So we do want to still see, as you saw that, yeah, we still do want to see flow around it. I mean, that's what we want to see, but I do think there is still contrast going through.
Yeah.
So we'll put in another coil. What'd you pick here?
It's an 1850.
Ah, okay. So Sid, who's literally a week or two away from finishing PGY6 and becoming an attending, has downsized our coil to 18. We like to usually downsize because then it starts filling the spaces in between our previous coil nest. Thoughts on that? Is that what you guys do, or how do you guys do it?
Same, yes. I sort of do like the Russian nesting doll, right, kind of thing, where big frame and then slowly start to downsize. If I feel like I have enough metal in there, I'll switch it to the packing coils, right, the even smaller sort of unshaped coils. Here, like obviously a packing coil would just leak out the back, so you don't have enough frame to switch to packing coils quite yet. Yeah.
Yeah, just like
Right.
Rahul said too,
So
and you're doing, and I like the fact that your fellow picked a 50 centimeter coil. Now that's obviously going to save money too in the long run because I think the longest pushable is like 14, 16 centimeters, right? Do you guys have longer pushables? So
I only those the nesters, right? The micro nesters are 14.
right, so this is basically 3 times the length of a micro nester. So I know it's still more expensive than a pushable, but it definitely like evens it out a little bit. So the fact that you can go with a longer coil in this situation.
Still doing it. Okay.
So your fellow's doing a really good job
Yeah.
in picking stuff.
He is. Now we're getting caught in this kind of outflow, and I'm trying to really change it a little bit so that we're not going into it and really just packing the aneurysm sac itself. But it really wants to go in there. I'm just going to try and reposition micro. You think it's a big deal that it's flipping in here?
I think it's worth
There
it.
you
You've been doing this just like that. Yeah, perfect.
Yeah.
Do you guys ever, and not in this case obviously, but do you ever put an occlusion balloon proximate like over the wire Fogarty or something to decrease flow into the spleen to have coils not fly off distally and have a little bit more control? It also like helps you kind of anchor your macro catheter, and then you put a micro catheter through the Fogarty to deploy your coils. That way it decreases the flow. Do you guys use that at all?
I have not, but that's interesting.
I've done it, I think, once, but I've not felt really a need to do it in most cases, but it's very clever.
Yeah.
It also tends to anchor your
16.
catheter so you can go further. Looks really nice. It looks like it's getting denser too, so it's probably clotting. Right.
Yeah, it's a good show of the technique. You basically, you're working the coil and the microcatheter together to get it to shape and form the way you kind of want. So,
yeah, and I think it's a nice application of detachable technology because I've been going back and forth because I haven't liked the fact that it was going into the outflow vessel. So it is a more of a controlled setting. Now, certainly there is an art, I think, with experience with pushable coils as well, but I do like the control that this does afford. What size is this?
Another 18.
Oh, okay, another 18. We should probably go down after this one to maybe a 10 or 12.
Yeah, the push-pull coils are great until your last one. Is a joke that I tell them.
Yeah.
Exactly.
Yeah, no, we've I'm sure we've all felt that during training quite a bit, where you want to just get one more coil. It's all out of good intentions, but that last coil can really hurt you sometimes.
Yeah. Yeah, I always say the last and the first and the last coil are the two hardest to put in. You know.
Absolutely. All right, so I'm just pushing this 18, then we're going to downsize to like a 10 or a 12, and then probably just do the inflow, and we should be done.
What's the smallest fiber size that you have?
Question, what is the smallest fiber size that we have? Yeah, it comes to a 2x4, and then there's also the softs as well. So if you have been watching my hands, every time we pull the wire, and before we insert the coil, we're always flushing the microcatheter. And I think that's very important because just the motion of pulling the wire in and out creates kind of a vacuum effect. And so you want to make sure that the inside of your microcatheter is flush to allow maximum lubricity, so that it is that even a word? So that there's no friction. Yeah.
It's a 1050.
All right. And so, I mean, I think the companies advise putting like a Y adapter on and then flushing as you push it. We just kind of flush around it or put it in a saline bowl, and that'll help so that we maintain that kind of easy pushability as it goes through the microcatheter. All right, this seems to be packing in quite nicely. And we can always check again with our system and flush or give an injection through the sheath as well. Let's go to a long 8. And again, very simple system of breaking, pulling to detach, and then pulling.
Yeah, I don't think they have a long 8. I mean, I think it's like an 830, right?
Oh, it's pretty perspective. 30 is kind of long for me, but maybe short for you.
Well, you were putting in 50s, right? So
Here's food for thought. Can we get forward on the side flush, please? Just for like 2 seconds, and then stop. Sometimes we deal with like the flush. Sometimes we deal with like really large aneurysms. I mean, insane aneurysms, whether it's in the portal system or someplace else. Let's say 30 millimeters or, God forbid, 40 millimeters. What do you guys use for that? Do you try and use 035s? Do you stick to 018s? Does it depend?
look, I mean, I think for giant aneurysms like that, if I can get an 035 catheter out, I would prefer to start using 035 coils just from a time perspective. The problem is the biggest 035, at least that we have, is 20 millimeters, right? Is the secondary loop. So usually it's not a big deal because usually the outflow vessels themselves aren't that big, so you can get away with it. And then just put put the 035, what we have 035 interlocks, and that'll work. I know Penumbra has their new 035 coils, which I think go up a bit bigger. But I haven't used them, so I don't know how they behave. Well, that one seems to be nice because it'll go through a glide cath, where the interlocks are a little bit more catheter dependent.
Yeah, I completely agree with you, Rahul. If I can get an 035 catheter in a big aneurysm, because the volume of coils you need is exponentially bigger as you go up. So, and I think Terumo still has those oiled coils that we have them here too. The name slips me, but
The Azores.
hydrogel coils that and they're a little stiff, but because they expand, they kind of have some advantage in big aneurysm stuff like that. But yeah, if you can go with 3.5, definitely.
So just to let you guys know, I'm at the origin of this splenic artery aneurysm, and really just at the proximal inflow vessel. So I'm going to just put a nice little coil in the inflow vessel and kind of call it a day. So we'll probably be deploying our last or second to last coil.
What size are you using for the inflow?
So we measured on the CT, it measured about 7.5 millimeters. And so here it is coming. The tip is right at the inflow right here. So we pulled an 8. And so that one, I want to be a little bit more precise. So I'm going to push my microcatheter forward. Let's see. It seems to be coiling.
Yeah.
Okay.
So I mean, considering that it's not going to go forward on you, right? Like because it has no place to go forward. Would you consider putting like a packing coil and just packing it in behind?
Oh, that's a good idea. Yeah, I would consider that. Do that.
So in general, how do you guys size your coils? Not in this case, but if you have a vessel, do you over, under, how much oversized do you go for your coils for vessels?
You know what? I try and size it actually as close to the vessel as possible. I think in the past we were kind of taught to oversize either 15-20%. But I think the coil, the imaging is quite accurate these days, and I believe that philosophy was really based off of calibration from DSAs, et cetera. But I think cross-sectional imaging really does allow an accurate measurement, et cetera. So I try and size slightly larger, but as close to the size as possible. What do you guys do? This is also, by the way, a very good sign. Before, we wouldn't have any backflow of blood. Now we do. So to me, that's a very good sign that we're towards the end.
I think from sizing, it depends on the type of coil, right? So I think the penumbra coils recommend to be more one-to-one sizing, depending on, especially for like their pods. I think Boston still recommends like a 15 to 20% oversize. I would still probably oversize a little bit. Like you said, you had a 7 millimeter vessel, you still put like an 8, right? Granted, there is no 7 millimeter coil. I think if I was trying to just do like a proximal splenic embolization for trauma, it's a little bit trickier. I think you have to oversize because I think CT tends to underestimate the size. I've done this. I mean, when we did trauma, we would think it's this size, and it always ends up being a little bit bigger than I thought. So, I mean, we don't do trauma anymore. So, I mean, I think you guys still do.
Yeah, no, at Georgetown, we don't get much trauma, but when I was at hospital center, definitely, like you said, I'm old school too. I oversize a little bit. And like you said, the coil determines it a little bit too, if it's really stiff or soft or whatever, and what setting you're in. So I oversize a little bit by like 10-15% for most coils.
It looks like that packing coil just sort of leaked into your aneurysm. And
it's just filling up quite nicely, creating a nice dense pack. So what we're gonna do is we'll do an angio after this. We're gonna set up to do an angio after.
Yeah, and I mean, maybe I'm just imagining this, but it seems like the coil pack is increasing in density, which is a good sign when it starts clotting, right? So.
Yeah, agree. Yeah, absolutely. Can we go forward on our injector, please?
Are you going to inject the sheath or the microcatheter? Sorry,
I'm going to inject the sheath.
Okay.
Okay. You're not Liz. Let's switch the anesthesiologist on us.
No, we're going to step out and do a run.
We're going to step out and we'll do a run.
So Ed, while you're stepping out to do the run, did you heparinize this patient during the case? Because you obviously have the sheath up around the celiac and splenic artery.
No, we did not. We did not heparinize. We have a side flush for sure with hepsane, but we didn't, for instance, like give any heparin.
Rose, do you usually heparinize your patients, or?
No, it depends. I think I've done, like when we do renal aneurysms, depending on how the setup is, if we're doing like we did a case recently where we used a carotid stent to do a carotid stent to use as a stent assist. And that one we heparinized just because we had such a big system across. We're not checking ACTs or anything, but just at the beginning when we're putting out the stent, just to heparinize a little bit so we don't get clot going distal. But typically, no. I think it's sort of like a one-off. So Ed, what do you think?
What do you guys think?
I think your aneurysm's closed, right? Clearly, because you have some infarcts, right? Some malperfusion. Although I've also been fooled like this, where it looks malperfused, but when you bring it back and inject from the proximal splenic artery, there's actually collaterals filling those especially from the left direction.
Yeah. So I agree with you guys. I think we're done here. Nice occlusion of the aneurysm sac. There is, as you said, malperfusion here, but just when you think, oh my God, and you tell the patient afterwards when they wake up, hey, next couple of weeks, you might feel, a lot of pain, this and that. Some of them do, but some of them come back and are like, no, it's totally fine. You do the MRI and somehow collaterals, even this distally, have opened up and created perfusion. Now, in her case, it's not a bad thing if some of this actually does undergo ischemia infarct, because it might help her a little bit with her portal hypertension as well. So she's got a lot of spleen to give. And so I'm okay with this. Emil, thoughts?
No, I think you're absolutely right. And but let's just play out the scenarios a little bit. If she does have infarction and pain, what do you guys usually do for that to help them with the pain? Because that can be really bad, right? Post-splenic infarction pain and stuff. So what do you guys generally do?
Sure. We generally give supportive care for that with pain meds. Now, we do have to be careful, obviously, with their history of cirrhosis and liver dysfunction. But she is Child-Pugh A, but we give some pain meds for that, and we would give some antibiotic coverage for this.
Yeah, sometimes, just like you said, we start out with that, and because this is more so in cases where we do distal embolization, we feel like giving steroids sometimes helps too with that stuff.
Sure.
And then we tried one time with a celiac plexus block too, and that helped a lot with those stuff. But
Absolutely. All right, guys. This is fun. All right, thank you.
Thanks, everybody. Thanks, Emil.
No, thanks for having me. You guys have a good day. That was a great case.
Thanks.